an argument I've heard from practicing physicians, and Ted, you can probably weigh in on frequency, but that it is so commonplace today to have a financial counselor in the practice, and that they were already doing that function, that it didn't really advance the cause at all, because that really was, that if the doctor was already determining a net health benefit by some mechanism, and the financial counselor was then meeting with them to understand their personal financial situation, that the framework, as applaudable as it is for what it tried to do, doesn't really advance our position.
That's right, and I think from a very practical level, that's so true, Bruce, because even to this day and age, small practices that are surviving basically have to have a financial counselor, or at least someone inherently that does that. I was on with a practice administrator recently, and it was really instructive, of a practice with 4 physicians. And the practice administrator said, "Can you hold on for a second? I have to answer a question." Took the phone, and she was, in essence, the financial counselor. She was saying, this is what, because they don't have a dedicated person. Obviously, in some big practices, they have teams of financial counselors. So I think that's an excellent point, that good efforts, and I agree with you, Alan, but again, I look at it from a practical level. They're already doing a lot of that. They have to, because if not, and I think you said this earlier, Mike, patient can't get the medication, or the patient is making the trade-off between groceries and the medication.
So let's separate out the cost issues and the financial counselor role, and whether or not a physician is actually in any way, shape, or form calculating a net health benefit, and I think that's a fallacy.
Oh yeah, all right.
I talk to oncologists a lot, and sometimes they don't like what I say, and I would challenge them. I would challenge them to tell me how they treated their last 10 metastatic lung cancer patients. Just tell me what you did the last 10. We can actually figure it out. All right, when you're done with that, tell me what your partner did with the last 10. And the answer is, they don't know. They don't know. So tell me how you're going to improve on that. You don't even know what you're doing at the beginning. So ASCO, to their credit, and actually Alan and I have met with them, understand that what they have is an imperfect tool, but they are trying to develop a process by which they improve the inputs to get a better product. And the separation of cost, because of the benefit design, a Medicare patient is different than a commercially insured patient, is different than a Medicaid, all that stuff, they put the cost thing separate, and they put the net health benefit based on toxicity and efficacy and
bonus points for palliative.
Yeah, and they also realize, as Alan pointed out, and it's absolutely true, efficacy may be really important to me, but maybe it's not quite as important to me if I understand that I have a terminal illness. Maybe efficacy goes a little bit lower where progression-free survival.
And to double down a little bit on the cost piece, though, it still doesn't address all the other costs. So it's only a cost on the treatment side, and not all the other costs that I already told. From a patient perspective, if you want to have a cost conversation, if you're not covering all those bases, from hospital costs to transportation costs to radiology, the top 5 things that patients, once you get past sort of the top 5 things in case management, there's a tie for sort of first place among specialists and primary care visits to doctors, other medical providers, radiologists, anesthesiologists, et cetera, then laboratory, and then prescriptions, all sort of tied for 4th, and then sort of right below that, surgery and radiology. So if you're not at least capturing the 5 or 6 things that patients identify as their primary sources of financial distress, especially for low-income patients, you're not really having a comprehensive conversation about cost that's going to mean something to the patient
and that
help
is
them
my problem.
With their